I'm muting my speaker. Joe, is my audio back on?
Yes, you're good to go.
Excellent. Okay. So first of all, thanks to everybody, both now and in the future, for joining this. And then thank you to Joe and Peter and Menti Calm for the opportunity to speak about this and engage in conversation about this today. For a little bit of housekeeping, for those of us who are Twitter users, if you want to harass me on Twitter, it's @2gonzo. And while you're at it, if you're pulling up Twitter, just keep your phones handy, because in about a minute or two, you're going to need to use them. The other thing is for those who are going to end up taking the post test, you'll notice that I'll be purposely repeating a couple of statements, and that's meant to be a little bit of a hint for you to keep some of that information at the back of your mind for that purpose. Get this thing to go. There we go. So I'd like to start actually, but before we get going, about explaining a bit about why I got involved in, what my motivation is about having conversations about this this area. And first of all, certainly some of it relates to my wanting to engage in advocacy for patients and families, and more importantly, to kind of help them find their own voices and advocate for themselves. But also I began to do, as I dug more deeply into this topic of stigma, what it is and how it comes about, I wanted to do something to maintain my own kind of awareness and accountability in doing my best to not facilitate stigmatization myself. So selfishly, having these conversations is part of keeping this in the front of my own thinking. And so I hope you find a similar value for yourselves. So to start off is like, what is stigma? What are we talking about? And if we look just sort of word roots in the dictionary, it's a mark of disgrace, and it's meant to be associated with a particular circumstance or characteristic or a certain person, and in effect, and even often by intent, it's a condition or status that ends up being subject to prejudice or discrimination by others. And further, the sociologist Erving Goffman was credited in saying that stigma is an attribute that links a person to an undesirable stereotype, leading other people to reduce them from a whole and usual person to a tainted, discounted one. And I will repeat this again. Remember, it's Goffman, and who says it was an attribute that links a person to an undesirable stereotype that leads other people to reduce the bearer from a whole and usual person to a tainted and discounted one. This is our one opportunity to be a little bit interactive today. So this is when you'll need to take out your phones. First thing though, I'd like people to do is where you are, just read this along with me. Parental X negatively affects fathers and mothers' caregiving and material support and nurturance, and is associated with poor health and developmental outcomes for children of all ages, including prenatally. X mothers are more likely than non-X mothers to have poor parenting skills and to have negative interactions with their children. Mothers who are X are less likely to use appropriate practices, such as using car seats, smoke alarms, and covering electrical outlets to prevent injury and harm among their children, and are more likely to use corporal punishment. Maternal X is a significant risk factor for child abuse and neglect. And so what I'd like for all of us to do is spend a minute thinking about what we think X is. And this is the part where we get to do a little bit of interaction. There it is. And what I'll have you do then is take out that phone, pull up a browser window, and direct yourself to menti.com, right up here. And then when that window opens up, you'll notice it tells you to prompt you to enter a code. And that's 514860, which is on the screen. And what you'll have is opportunity, what we're going to build together is a little bit of a word cloud, and you can put up to two entries. And so it's basically what you think X is. And I'll give people a minute to start doing that. See some responses starting to come in. You'll see the number at the lower right part of your screen. And I'll wait for us to get to 30 or so, and then I'll show our accumulating results. close enough, we'll pull it up. And so for those people who are familiar with word clouds, the more a certain term is used, the bigger the font size is on it. And there are many answers that are correct or can be implied here. The purpose of doing this is to kind of demonstrate, if you look, the number one that's showing up in there is addiction, and then a number of the other ones, because the word isn't exactly the same, is still things like substance use, substance abuse, point being that the predominant answer, and I've done this a few times with a number of participatory groups, that addiction or substance use seems to be the first one that comes to mind for people. I'm going to let that keep accumulating. Please continue to send your answers in, because this is something that we can save, and I can share these results with people later. So it may or may not be surprising to people that in this case, X actually refers to parental depression. And this is from a group called childtrends.org that puts together compendiums of research in different areas that are important for child health. And so I noticed that depression did come up among other things. There are many circumstances and diagnoses that are risk factors for the experience of abuse or neglect. And in this case, what I wanted to highlight, I was both, not surprised, but it is interesting that there's still sort of a bent towards substance use, addiction, related terms and diagnoses to be the first thing that comes to mind for people, even though in fact it's not any more of a risk factor for child abuse and neglect than depression is. And so it's got more weight to it than its weight as a risk factor. And like I said, please continue to send results in, because I can share these with people after if they would like a copy of the results. Okay, for that part. So I want to shift gears a little bit related to this, is that there's stigma around prenatal and maternal substance use that influences perceptions of parenting ability and fuels punitive responses. And so there's a stereotype, particularly among women of color, that substance use makes them incompetent as parents. And in fact, that's untrue. Like we said, that combined with other factors can make a situation that's at risk for abuse or neglect to happen, but it's not tantamount. Substance use disorder is not tantamount to ineffective parenting or inability to parent. Substance use disorder alone then does not make someone an incompetent parent. I'm going to repeat that twice because this may come up again. Substance use disorder alone does not make someone ineffective or unable to be a parent. And substance use disorder as a marker is no greater risk than parental depression for experiencing abuse or neglect or any of those other things that were highlighted in that paragraph. Studies indicate that fear of behavioral health related stigma is especially strong among migrant and other marginalized groups, and this is stigma amplification that occurs when an individual is a member of two or more marginalized groups. And I'm going to repeat that. Fear of behavioral health related stigma or any other stigma is especially strong among basically people who are members of two or more marginalized groups, and we refer to that as stigma amplification. Furthermore, many studies have been conducted on racial inequities within the child welfare system. And we do know that even though disproportionate to their representation in the population, Black children, and certainly in Minnesota, Native American children as well, are more likely to have substantiated claims of child maltreatment and more likely to be removed and put into foster care. So it's disproportionate. And in fact, Black children are up to twice as likely than kids from white families to be put into foster care. Again, showing some double bias or double disparity. So I want to talk a little bit more about assumptions, and when we look at what factors into someone's behavior, what do we look at? And in social psychology, there's something called fundamental attribution error, sometimes referred to correspondence bias or attribution effect. The example I usually like to use, it's a little difficult to have that to do that here in a participatory fashion, is what happens when we're in traffic. And the thoughts that we usually have when somebody cuts us off. Usually we end up saying things, calling them names and sort of attributing why they're doing something to things about them and their character. Where if we then turn around and think about when we cut somebody off in traffic, we'll often factor in things that we're internally aware of, which has to do with things like we're distracted, we're under stress, or we simply made a mistake, we're sorry. And so it's this tendency to overvalue dispositional or character-based explanations for behavior we observe in others, while undervaluing situational and contextual explanations for those behaviors. And again, that's the fundamental attribution error. And getting back to the question about child abuse and neglect, in looking at researching risk factors, originally the research really focused on psychological or personality characteristics, particularly of mothers. And later what we learned to do is look at more systemic and other issues like family members, the family system, and environmental milieu. So again, what we learn from social and medical science and looking at these things is really impacted by the quality of the question, the type of the question, and it's absolutely influenced by bias, or in this case, attribution errors that we apply to it. And as we'll see later, the same is true in substance use disorder. So we have overlapping and intersecting themes. Stigma is something that in many cases is manufactured. It's a manufactured something or someone for people or institutions to blame or control. And we've seen this historically. There's only one reason why men become addicted to drugs. They're weak men. Only strong men are cured, and they cure themselves. This is from Martin Fisher, who is a physician and a physiologist, and if you ask me, a jerk. And unfortunately, as a physician, the settings in which I work, this is very reflective of medical culture, not only on an individual level with patients and families, but on a systemic level. And it's what patients and those of us who work in those settings face every day. Stereotype is a fixed, overgeneralized belief about a particular group or class of people. And as we're generating, or how stigma comes about, people are identified, or group is identified as different. In this illustration, we're using the example of HIV. And people are identified as different. They get labeled as dangerous, somebody that we need to fear, somebody we need to exclude or punish, or something else that's basically never something positive. In the case of substance use, a lot of the stereotypes which we've all heard or experienced are things that they're morally bankrupt, they're selfish, they're dishonest, they're weak, they're dangerous, or even criminal. And you can easily see how that lends itself to not only fear, exclusion, and certainly barriers to access for a lot of resources and support that people might need. This is just an illustration of one way to break down stigma and its different types of spheres and types. One in particular I want to make sure we pay attention to is structural, but we'll start with public and self, which is often what people are usually talking about. Again, stigma is something that comes with what's reflected for people socially and the folks around them, and that's where they hear things or get responded to with shaming and disparaging in terms of how they're characterized. Again, selfish, weak, why are you doing this? You can't, do something different. They have a choice, and that they're, like I said, criminal, and they're all sorts of basically negative things. Self-stigma is when the person pays attention to what's being reflected for them and said to them, and they internalize it. And we'll talk a little bit later about some of the outcomes of people internalizing what other people are saying and what systems are saying as part of their reality. I would like, all of these are important, but I particularly want us to pay attention to type 6 again, which is that structural stigma. And that's, policies or other structures that result in decreased opportunities with people with, in this case, mental illness, but any stigmatized state or condition, that's considered part of structural stigma. And we're all kind of part of that. And like I said at the very beginning, even though I may not be directly intending or doing this with someone, when I'm part of systems or part of not calling out systems that are part of keeping these things in place, I'm really part of facilitating it continuing to happen. On the flip side is if we're looking for ways in which changing things, whether by advocacy or in our roles administratively or in terms of sort of educating our peers or educating systems, it's important to keep in mind, be able to see where evidence of structural stigma can be happening and start to think solution focused on that level. So again, something to keep in mind, I'm repeating this, structural stigma is those institution policies or other structures that result in decreased opportunities for people with a stigmatized condition, and those are considered structural stigma. A little bit about the racialization of addiction and stigma. Stigma is absolutely oppressive and racist and classist and sexist, and in any way that it's intended to, again, exclude, control, or otherwise kind of keep people out of opportunity or power. In this case, this was the former head of the Federal Bureau of Narcotics. Marijuana is taken by musicians, and I'm not talking about the good musicians, but the jazz type. And I think, I can't hear the back and forth conversation, but I'm sure it doesn't take anybody long to realize who we're talking about as African Americans. And this was the, one of the beginning part of trying to criminalize the use of cannabis, and it was done with racial intent. Brains do not differentiate between licit and illicit substances. Laws do, people do, institutions do, and they do so with a purpose. In this case, stigma is also self-serving and convenient, and in this case, it's a privilege. It's privilege that represents that. Linda McCartney here quoted as saying, "I think hard drugs are disgusting, but I must say I think marijuana is pretty lightweight." And at first that might sound like it's kind of maybe like benign, or is it pro-pot or something like that, but it comes from a statement that comes from a position of somebody who's white and of a privileged class, who's not impacted the way other people are. In many states, as we know, you can end up with significant prison time for the possession of any amount of cannabis, and it preferentially impacts communities of color. And so again, stigma you can be part of it by not recognizing your privilege, and so it can be actually quite convenient for people. The other is stigma is, in fact, often pretty hypocritical. So again, licit, illicit, and the forces that get something to have a legal status or an illegal status. This is from William S. Burroughs, who was famous for taking multiple substances other than alcohol. Our national drug is alcohol. We tend to regard the use of any other drug with special horror. And actually, even within alcohol use, I mean, any of us who are on social media, on Facebook, we'll see different pages saying, "Mommy needs wine, Daddy needs a beer," people, making jokes all around it. And yet there's this line that eventually, some people cross if they develop a problem with it, is that how is it that it's okay for everybody else, but if you cross that line, you've become that person with a problem. And again, because of the stigmatization of it, that person automatically gets less value than the rest of people who use alcohol perceivingly undetected. And again, it more preferentially negatively impacts people who are members of marginalized groups. I want to shift gears a little bit to talking about healthcare stigma and the language that gets used there, and how it promotes stigma in healthcare settings. This is from John Kelly's group in Boston. When we talk about things like diabetes or high blood pressure or any other sort of accepted medical condition, we talk about them as, in this case, as having an elevated glucose level, or if they have cardiovascular disease, they may have a positive stress test. And a clinician is expected to address those results. And then when it comes to somebody who's dealing with a substance use issue, they're referred to as an addict, and also, not as the person that they are. It's they're an addict. They're clean or dirty. They've been abusing substances, which refers really to some extent as something volitional almost. Again, putting the responsibility entirely on them. And then we talk about dirty urine samples. And as we've all seen, people often end up having this addressed or not addressed in the criminal justice system. And when they do get care, it's separated oftentimes from the rest of healthcare. And I'll tell you from a personal experience, I recently saw a patient who was essentially blamed and shamed by a consulting provider for having a stroke. And this person does have a substance use history, but what they did is they attributed the stroke to the substance use problem when this person had multiple other additional risk factors, first of all, for having that stroke in the first place. And they also sort of implied that she had her almost own responsibility for why it happened and for basically doing something about it after. And of course, she has to participate in care. But what stood out for me, number one, was shaming her and not only giving her responsibility for a really devastating medical outcome, but the fact that they really overlooked investigating the other multiple contributing factors to a stroke. And this happens all the time. And this is just talking about in medical settings. So the experience then of what stigma feels like, and I like to remind myself of this, is people end up feeling excluded, isolated, unvalued, unworthy, and incapable, often disempowered. And where we often then end up seeing this, right, is in how we perceive how somebody is or isn't engaging in treatment, which I'll talk about a little bit further. The other thing I want to talk about is the fact that when people have internalized stigma, so experience self-stigma, that it does impact cognitive function. So in this case, what the researchers looked at was attentional bias, and there was more of an attentional bias towards stigma-related words in people who showed really high self-stigmatization. Now, it doesn't completely flesh out why exactly this happens, or were certain people more vulnerable to having more self-stigma than others. But what it does suggest is that stigma and its perception is mediating something, and it's at the level of attentional shifts and what our brains pay attention to. Again, getting back to those stereotypes of weak, selfish, lazy, dangerous, people internalize it, and then it thereby affects, lowers people's self-esteem, lowers their self-efficacy, and also lowers, again, their participation in life and in treatment situations. And some of what it's referred to in some of the literature is this why try effect. And if you think about it, right, they internalize some of these negative attributes, and it gives them the message to themselves that I'm not good and I'm not capable. And so what they tend to do is go through these cycles of avoidance, anger, and what appears to be apathy. And sometimes in treatment settings or any just sort of professional setting, we might label as somebody as being in denial, again, like it's some, whether it's a volitional thing or we say that it's just part of the illness that they have, rather than seeing how some of this cycle can be contributing to how people are no longer connected with their value or their ability to participate and be healthy and get better. And we call that, like I said, may call it unengaged or in denial, when it really has to do with a lot of more system pressures and factors for why somebody ended up behaving and thinking the way that they do. Another way of stating that, in my view, stigma is oppression. From Biko, the most potent weapon of the oppressor is the mind of the oppressed. And again, keeping in mind that sometimes we unwittingly contribute to stigmatization, and many times, though, systems and institutional structure are doing it and using it as a weapon on purpose to sort of keep people in this disempowered state. So it's very much suppressive. And this example, I'd say racialized attitudes towards addiction have been with us for over a century. Although in my view and many others, I think the response to the ongoing opioid crisis is yet another example of it. Part of the response, if we compare it to what happened with the crack baby epidemic that actually never was, there was a crack epidemic, but not this crack baby, but also the demonization, particularly of mothers and communities of color. And we responded a lot more, like I said, in terms of being disparaging, criminalizing, demonizing people, and versus what we're trying to do with the opioids, which is predominantly a young white male problem, especially when you're talking about heroin in particular. And so just the response alone has been different and more supportive. And yet there's still a further racialization by it in terms of when you look at who's going in to foster care situations, we're attributing that to the uptick in a lot of heroin addiction. On the other hand, a disproportionate amount of those kids are from, particularly in Minnesota, Black and Native American communities. Across the country, it disproportionately affects Black families. When it comes to things like medications for the treatment of opioid addiction, Black and Native American in particular have decreased, limited access, particularly to buprenorphine. And so there's an overall painting of how it is that we're responding to this particular substance problem that shows racial bias. And then still within that, there's, again, barriers to access for care that falls along racial and ethnic lines. Another way in which I want to kind of highlight how sort of bias and assumptions and sort of misattribution can impact things is through diagnoses and the research around diagnoses and intervention. And the first thing, part one, I want to talk about a little bit is categorical versus dimensional classifications. And so for those of us with familiarity with the Diagnostic and Statistic Manual, that's really more along the categorical classification. Even though we have these long list of symptoms, it ends up being you meet that criteria, you don't. And in the other or global medical world, in this example, we talk about high blood pressure. And in categorical classification, we just say there's this line, you either have high blood pressure, you don't. An alternative or an additional view is to use dimensional classification. And that's where you have a measure that's on some kind of continuum, and somewhere there's a threshold for diagnosis. So there's a little bit more granularity within the dimensions. And why I'm mentioning this, we'll get a little bit to more recent ways in which people have been looking at diagnoses. Reasons for taking advantage of something like DSM, of course, which is categorical, is it's easier to use clinically, and it's kind of a little bit easier with decision making. Problems with it have to do with, of course, we've all seen overlap between multiple diagnoses and this what I call artificial comorbidity. Are we really talking about multiple different diagnoses? Or are we just not looking at this in the right way to be able to get at one unifying diagnosis or problem area? And I think a good example of this, for those who have heard of transdiagnosis, and that's going into part two, is, and this, we really saw this originally in the eating disorder world, where clinicians and researchers in that setting were starting to see a lot of movement between, say, people who started out with an anorexia nervosa, move into bulimia nervosa, move into binge eating, move in and out of this then not otherwise specified category. And they're like puzzles, like why, if these are real distinct diagnoses or problems, why is there so much movement between them? And so they started to look for these, we call it transdiagnostic factors or symptoms or pathologies that would kind of explain, like, was there something that crossed diagnoses? And in that setting, early on, they came up with the whole idea of the over-evaluation of weight and shape was something that tied all of them together. And eventually what they did do, and you'll see in this picture here, this was from a study looking at basically everything that had been done so far transdiagnostically in psychiatry. And early on, when they included substance use, I think reflecting a lot of bias, was they referred to it in an externalizing category, and along with disorders of conduct and things like antisocial personality. More recently, there's been more shift towards asking things like, where might there be transdiagnosis or cross-diagnosis with things more common like anxiety and depression and things like that. So it's taken a while to get there, but again, you have to think about how has our case formulation and our interventions and our treatment planning been colored by the research so far. And so there's going to be a lot that we're going to, a lot to learn and a lot more that's going to change in terms of interventions when we really expand our thinking in terms of just sort of how to think about substance use in the whole complement of everything else for what makes up a person's sort of psychiatric makeup and what other disorders they might have. I want to switch gears a little bit too in terms of our bias and our history in terms of how we've responded to substance use when other psychiatric issues have been present. In this case, something that I've been working closely with another group on here is the first episode of psychosis. So a lot of people probably have some familiarity with research that shows that early on, so adolescent cannabis use, if you start in the adolescent period, there's a greater increased risk of that person experiencing a first episode of psychosis. We incompletely understand like what component of it might be causative, whether there not be maybe shared vulnerabilities for different things, but there's no question as sort of a marker of risk that adolescent cannabis use increases risk for the onset of early onset psychosis. What isn't quite clear then is when we get them in treatment settings, it's not as clear cut what to do about that cannabis use once somebody has started entering treatment. And we're, in some settings, it may be, or some of the research has demonstrated really that there's no difference in terms of first episode outcome. And so there's a lot of questions yet to ask, but the point being this idea, especially what we used to do, which was you have to take care of your substance use before we can address the rest of your psychiatric issue, or it has to be stable, or all these other things, is that in addition to integrating treatment is going back and readdressing what type of interventions actually need to happen, including what will really be hard to many people to let go of is at what point does you say for the particular outcome you're looking at that treatment as usual for substance use, including having a goal of having somebody be abstinent, may not be what's needed in this case to have a good or improved outcome in the first episode of psychosis. So again, like I said, is expanding our thinking and taking away or getting away from old assumptions and stuff that's been hardwired into us in terms of what we think treatment goals actually should be. Related to that, I just want to put out a little caution about how we've been using the word evidence-based. This is going back 20 years when this whole concept started to come into being. And evidence-based medicine is a conscientious, explicit, and judicious use of current best evidence in the making decisions about the care of individual patients. So it really has to do with, in that interaction that you and I have with a patient and their family, it's about pulling all of what's available in terms of evidence, including the lack of evidence, and being transparent with ourselves and that patient and family about our thought process and how we're going to have a conversation about what may be the best decision that they can make about their care. What evidence-based is not, but it's kind of been turned into, is this idea that, say you pull up the website for a treatment program and it says, we do evidence-based, CBT, evidence-based, and like that's actually not what evidence-based is. That's the research from which evidence-based practice arises, but you don't just like globally have an intervention for an entire treatment population and say that that's evidence-based. So like I said, it's just cautioning all of us to be cautious about the use of that term. Another thing I wanted, or a final thing that I wanted to talk about before we get to some questions and discussion is cautioning us about the whole concept of dual diagnosis, and not only intellectually or what it might be, but in terms of advocacy, and again, how it could contribute to stigmatization and barriers to access. So I am going to read a little bit. This is actually from, as you can see, I'm talking about dual diagnosis in the setting of people with behavioral health conditions or psychiatric conditions and intellectual disability. And what I want to talk about, what I'll do is read this because I think that we can insert substance use in place of intellectual disability here. So while such a term, dual diagnosis, may have some advocacy rationale aimed at facilitating improved mental health care for those with intellectual disability or substance use disorder. It's proposed that that construct has flawed underpinnings, and its application may problematize mental health service delivery, which I think we've all seen. A core concern is the promotion of categorical models, which we discussed, where a dimensional model may more accurately reflect underlying continuums for people with both substance use and other psychiatric challenges. So a categorical approach may also contribute to questionable dichotomization of behavioral health difficulties with people who also experience substance use disorder. And organizing services based on beliefs that such distinctions are accurate may contribute to unnecessary, inappropriate fractionation of interventions and create additional service barriers for a vulnerable population. And I think, you know, many of us have seen this in part with silos, care silos, but also silos, say, within an institution when they separate off substance use from the rest of behavioral health care. Care is disintegrated between multiple different providers and care system. And there's this artificial specialization, right? People like me who are addiction medicine specialists, which I personally don't believe in, that access then to people like me is limited, and access to services. And it also, in many cases, ends up being lower quality psychiatric care in settings that end up really, number one, maybe focusing or over-focusing on substance use outcomes as the primary, without having adequate resources and certification and expertise of the people who are there are supposed to be taking care of psychiatric and psychological concerns. So again, like I said, it's just a question, but asking us for beyond the academic to really question the impact of continuing to have dual diagnosis as a concept, dual diagnosis as a term, and how we respond and bring resources to bear for people with that remaining category. I'll close with saying that I have no disclosures. I get paid less to think more, and we didn't talk about any off-label or controverted treatments. And some takeaways for you and myself to kind of walk around with constant reminders of is recognizing that stigma is oppression and oppressive, acknowledging it and naming it. What I mean is, like I said, not only in systems with working with colleagues, but I also do this with patients and families. When I recognize that there's something about access or how they're being treated or how things are being made difficult for them, is that even though in the moment I may not be able to do anything about it, is validating for them that it's present and that it's inappropriate and that it's difficult, so that they're not alone with it. Always remembering to use person-centered language, avoiding guilt and shame tactics and anything that may imply that. Emphasizing their strengths and promoting their resilience, remembering particularly the impact that stigma has when they internalize it. And again, looking for ways in which you and I may be facilitating institutional stigma, so that we can constantly be working on ways to both not contribute to it and think about system level solutions. And with that, I will go to the chat box and see what people have.
Hello, Lucien. We have a few questions that came in. Sophie.
Okay. Say that again?
Sorry, I was on mute here.
Oh, okay.
Sophie pointed out, it would be good to point out at some point that even in the activity you did right at the onset of the presentation, that some people use stigmatizing language, such as mentally ill.
Absolutely, absolutely, and thank you for, because that your example of bringing that up is also just important of, and it gets tiresome, and yet every time that we're able to do that, it's like I said, it's just really important. And you're right, I also have the tendency, because I may be focused on a particular area, that I end up not picking that up. So absolutely, and thank you for doing that, for doing that as an example.
And there are two more questions
Sure.
that do a little overlap, and I'll let you parse those out.
Sure.
Chris says, so is it better to use the term sober or in recovery versus talking about being clean?
Wonderful question, and that highlights a resource I want to give you in addition to some comments I'll give about it. There's something called, if you Google a dictionary, ADDICTIONARY. It's from the Recovery Resource Institute. It's in Massachusetts, but this online resource that goes through, it's a glossary of terms, and a big part of it is meant to, there's the education piece about what those terms mean, but it also has this item called stigma alert. And some of them people may be back and forth on, but some of them are clearly stigmatizing, and not only because of what people think. Research has supported not using things like abuse anymore. In any event, I find that kind of a helpful resource. And as people are starting to think more about this themselves, they can also share that with others. And I refer to it myself. So then getting back to sober or in recovery, I think part of it really, in part, has to do with tone. I think sober, especially also for people who participate in 12-step recovery, that's a term of wellness and pride for them. So I think part of it also has to do with, particularly when we're interacting with that person, is what term would they like us to use, for one thing. And then what do you mean by it? Because when people say sober or not sober, it's almost like it can be, in the user's mind, just a different version of saying clean or not. And again, like I said, it's words are just so complicated, and you can't necessarily read into people's tone. And again, I think it's as more important how the person is using their terms to promote their own sort of self-efficacy, but also their self-respect. In recovery, I mean, a lot of people have said, you've probably heard this term, people, instead of saying relapse prevention, we'll talk about things like recovery enhancement. And so a lot of people really, it resonates with them a lot to say in recovery. I think one of the difficulties with it, and remember, so I do work with adults, but I predominantly work with kids. And for many of them, we can talk forever about the way that the DSM is irrelevant to everybody, but it's super not relevant to many, many kids when it comes to substance use. It's something that we need to intervene on, certainly, because there are a lot of safety issues and other things involved, but they don't often meet criteria for substance use disorder. And yet we do. We label them with it. We label them with it probably irresponsibly. And then we talk about them being in recovery. And for many of them, they will be. There are many kids who are going to go on to have to manage this or for a long time. And many kids won't, and many young adults won't. And there's this something we used to refer to, particularly in alcohol, where we talk about an episodic pattern, or somebody might have a single episode of a problem with alcohol and then never look back. They get support for it in whatever form, it resolves, and they're done. And do we refer to that person as in recovery, or have they had an episode that's just over? So we've been sort of colored, if you will, I think in part by both 12-step model as well as the addiction as a disease model, that every person who runs into that, they have a chronic relaxing condition, and that may not always be the case. So that's going a little too far. But the bottom line is, I'd say sober or in recovery is certainly less stigmatizing than clean or dirty, and ask the patient what terms they like to use. Okay, sorry.
Thank you, Lucien. Leandra says, can you comment on how this impacts those in 12-step groups who habitually label themselves as alcoholics/addicts? Also, isn't the DSM-5 stigma-based then too, because it has labels practitioners use to diagnose clients?
Oh, wonderful. So let's start with the first one, because there was and Joe, just by the way, if I provide further like links to papers or things like that, is that something that can be posted with the webinar so that people can get them later? Or
send me anything you want, and
okay.
I'll be glad to send it to everyone in attendance today. That's not a problem.
Great. And it gets specifically at Leandra's first part of her question about the labeling. And so there was an article that just came out, maybe people saw, it was about 2 weeks ago, and it was about patients saying that I get to call myself that. And if you think about it, also, I'm going to raise my hands in the queer community, right? You don't get to call me that, but there can be some, as a group, empowerment in terms of adopting use of a certain term for themselves as a group, and in this case, individually. And in one of the cases that they highlight from this paper is that, patient says, I can call myself an addict, but I'd prefer that you didn't. And so it's not only about it being stigmatizing, again, it's respect. It's personally, it's just like when you ask somebody what their preferred name is, do you have a nickname? Don't nickname me. I'm going to tell you what my nickname is. It's the same thing here. It's just like asking them, like, I'm not going to use that word, but what words do you use? That said, do I think it's stigmatizing? I do. And at the same time, we have to walk this line between, I don't correct patients. I just use different language, and so that they can hear me talking about them in ways that talk about them as a whole person and being very respectful. They can continue to use whatever terms that they want. Because again, it's not any more respectful to have somebody tell you, well, you're not that, don't talk. I'm not going to correct them, because that's uncool. Do I think DSM is stigma-based? I do, and it's also incomplete, right? It really gets at still sort of one type of way to have a problem with substance use. So we don't really have a way of, in DSM form, getting at what struggles somebody's have. ICD gives us a couple of different options, but even that's incomplete, including, like, say, in an adult, they may be exhibiting what you consider to be high risk use, in part because of medical or psychiatric impact, but they haven't developed this syndrome that is really, moving towards addiction, or the early stages of addiction, which not everybody has. The other, if you ask me, looking at the criteria, they're not very patient-centered. And so when we moved from DSM-4, which you'll recall still had abuse and dependence, collectively we had 11 criterion. And then when we moved to 5, we also had 11, but what we did is we got rid of the legal, and we finally included the experience of craving or preoccupation. That's the only one that's clearly patient-centered, although it's very much impacted by how we define what that symptom experience might be. The rest of it really talks about the ways in which they're failing in their lives or failing other people. I think we can go much further in terms of being able to be patient-centered about how to talk about those things. For an example, when we talk about failure to fulfill major role obligations, that sounds to me like you're talking about the way in which somebody is failing or disappointing others. How about they are not able to be present for their life because of whatever reason? Depression combined with their drinking is making it hard for them to have room to pay attention to what they really want to pay attention to. They cannot be present, or they are so experiencing craving that as much as they're digging their teeth in and not using, they're continuing to be preoccupied, and so they can't engage, they can't think about anything else. And so I think where it's, like I said, people can argue what the intent of a criterion is, and it's still, to me, I agree, it still reads as kind of judgy, and it sort of enhances the any part of us when we're weakened, when we're posed with certain clinical situation, it's a little bit geared more towards being judgy and blamey than to get inside the psyche and the experience of the patient.
Thank you, Lucien. We have a comment here from Ken, and I believe Ken's speaking from clinical experience, and Ken says, many clients are glad to know there's a diagnosis for their emotional distress, that it is a recognized and legitimate category, and that treatment options have been identified for the diagnosis. Thank you, Ken.
Hi, thanks. Thank you, Dr. Winters. And agree 1,000%, obviously. And I think, though, I would argue that this is a case where actual evidence-based medicine comes into play, right? And so, because in that individual setting, you have that conversation with them, and you're able to kind of say, this is what we've got here. This is where these criteria come from. These are where the research that indicates that for your kid in that age group and the type of situation they have, that this is, say, the therapeutic modality that's recommended and what that research is based on. And we have opportunity to include where it falls short, how we're thinking about, expanding on how we're thinking about the problem, because as practitioners, we do think about things dimensionally, and we do pull in things like issues of, social influences of health and the reality that these are existing in. So I would say yes, and to not throw this out the window, and yet evidence-based practice allows us to add those other pieces, including the transparency of what some of both the limitations may be of what's there, and also where we're kind of making recommendations that are based on our clinical experiences or something special about that patient that doesn't exactly fit either into DSM or the straightforward, like, sort of execution of a manual-based therapy, for example, if that makes sense.
Great, thank you. Thank you for the great questions, everyone. Keep them coming.
These are awesome.
We have several more here if you're up for it, Lucien.
Sure.
So Allison asks, how can I support families and parents experiencing challenges with substance use while holding my role as a mandated reporter and being purposeful in increasing my awareness of internal biases of when it may enter the realm of endangering the child, all while not stigmatizing the parent when engaging them in these difficult conversations?
Woo, that's a good one. I think, what's really awesome is the fact that you're asking that question. And why am I saying that? Because in the recent reading that I've been doing, looking specifically in child welfare settings of helping increase awareness among the people working in that setting, is that there are issues beyond just systemic or individual centered that account for those practices, meaning there's something about the human being who's looking at the data to take the call and make a determination and even assessing risk level. And so in that setting, even when, let's say, the kid in the from the Black family is assessed at a lower risk, they're more likely to have a substantiated claim. My point with that had to do with, out of some of these studies, what they're realizing, that getting people to at least ask the question of realizing that we're all subject to bias, and that we need to, by beginning to be able to do it, is exactly what you said. I'm reading your question of increasing my awareness. And you increase your awareness by asking, is that here? And one of the other things that I tend to do, and I didn't do it today, but I'll do it now in terms of my lens. So today I'm here with the lens of Mexican, Spanish, Irish, Catholic, Jewish, queer. And why I need to own that coming in is both to recognize the way in which privilege and non-privilege and my cultural and other background lens influence where some of my viewpoints may be coming from. And so it's the same thing here, is by being able to say, I see difference, or I don't see difference, and should I? What subtle things might be getting into my thinking? The other thing is, particularly when it comes to being mandated reporter, because obviously I am too, and I'm guaranteed everybody on this call is taking substance use away. What do I think is putting this child either in danger or in a setting where their basic needs are not being accounted for? Is my brain saying that I think their substance use alone means they can't do their job? It is an ACE, right, an adverse child experience for that kid, and yet that's something that can be dealt with. It isn't necessarily automatically a child welfare issue. And so I find it, like I said, it helps me both in thinking about those cases myself, but also when having, mutual consultation with others, is take substance use out of the picture. What is telling you that there's a question of neglect or maltreatment in this setting, if that makes sense?
Thank you. Sophie has a question here. It's a little longer one. I also find that stigmatizing and dehumanizing language is heavily used in the corrections and criminal injustice system. For example, offender, sex offender, felon, inmate, etc. I get a lot of pushback from staff working in these fields when I challenge this language. Do you have any tips for challenging people associated with this specific area of work, an area that is rampant with racial disparities? Everyone seems totally on board about person-centered / non-stigmatizing language until it comes to people who've been in prison or otherwise involved in the criminal injustice system.
Oh, I love it. No, absolutely. And I, again, like you said, I see multiple points of absolute agreement and right on in terms of what you're pointing out. Number one, like you said, is stigma as oppression is visited in all sorts of areas, because what have they done here? They've dehumanized this person. It's offender, it's felon, it's inmate. And arguments that people will make is that, well, it's that way you just know who I'm talking about. It's shorthand. It's like, but it's disparaging shorthand. And so again, people internalize this. And, you know, even if substance use isn't something that's involved, say it's, you know, somebody, it was armed robbery, whatever it was, it's how is that person is expected to take a different trajectory when there's like pressures that just kind of say offender, felon, you're a bad person. You know, you're wired that way, whatever. And so I think what you highlight is that, again, stigma as oppression, stigma as purposeful, and stigma as as institutionalized. They're contributing to it even before we add substance use to it. Now you add substance use when you look at the person who's in jail for purely drug-related crime, and now they're not only not getting attention to whatever other factors, you know, got them to the place they are in the first place, but they're not getting connected to appropriate, affirming, respectful care, for one thing. I don't know exactly who you're talking. What I can say from my experience with work, so I've done work with the Federal Judicial Center, where I've done part of education sessions for groups that either have developed or are developing problem-solving courts in the federal system. And what I have found is they see some of the same problems that we do. They want to be, they actually want to be helpful. They realize that a lot of people either really don't belong there, or they do, and you still, just because you know, say, need a correction situation because of your violent offense, you're still a human being who may need varying types of behavioral health support or other issues. And so it helps for them to hear the different language when they realize the impact that it has. And that's the feedback that I've gotten when I do some of this education, is that they need to hear it, and they'll continue to oops and ouch. And just like with you know, what a lot of diversity inclusion efforts that are, I don't want to say successful because it's not one and done, but when we create environments where it's safe to be called out and have conversations, this is a similar setting where if you have increased conversations with people and just kind of say, you know, we know of the impact that this has on folks. This is the type of language, this is the impact that it has when you use that. Here are alternatives. People do, you know, for the most part, are trying to do better. And oftentimes it's us being quiet that contributes to it continuing, rather than some people having opportunity to view things and speak about things in a different way. Your questions are awesome.
Thank you. Thank you. I have two here that I believe there's a little overlap with again, and I'll let you determine that.
Okay.
Emily says, what part do you think insurance plays in the stigma of co-occurring disorders? And Dinara asks, can you comment on the changes hospitals or healthcare agencies are making to change policy to help accommodate patients' rights with those with a history of mental illness or substance use?
So first, I'll tackle the insurance thing. As we've all experienced, the problem with, you know, even though in the front of the DSM, they say it's like, this isn't meant to be like the end all be all of what you use diagnostically. This is what its potential value is, and this shouldn't be the only thing that you use. And yeah, we've all, those of us who bill know that you have to have something, there's no payment. And so a lot of people feel like they're kind of forced into situations where they have to pick something that may not fit, or they just don't have anything. And I think a lot of us have seen an overuse of even things like adjustment disorder, where it's just like, I'm going to get you something so you can use your insurance. That has huge impact. An adjustment disorder isn't just, you know, like a benign thing. It means you're saying that you have symptoms that are enough that they're causing disruption and dysfunction in somebody's life. That isn't something that's appropriate for somebody who, say, they're having a life transition change, something stressor in their life, and they're proactively seeking out some psychotherapy, for instance. They have to be, it's a system that's geared towards pathologizing when there isn't necessarily pathology there. Actually, sometimes people seeking out support is a sign of wellness. And so again, you have some wiggle room in there. But also pathologizes more people who have to rely on their insurance. There are a lot of people, if they have means, will pay out of pocket for stuff. And that's not very many people. But again, how are those people going to be clued into the fact of how this disproportionately impacts not only people who are marginalized, but just people of lesser economic means on a whole? They're going to be more pathologized than other people are. So bottom line is, yes, I think insurance contributes to this. And what was is the question of hospitals and healthcare agencies. I guess, well, I guess one of the comments I would have, which is one of the struggles that I run into, and I won't say details because this is going to be recorded, but there are systems have to kind of see this and improve themselves as part of advocating for patients. And what do I mean? I've seen myself in my own institution several examples of where systemic stigma has led to barriers to access, barriers to psychiatric hospital beds, barriers to being admitted to other levels of care, other service. And so I think we have, like, on a systemic level, a lot of institutions really, there needs to be some type of awakening and key people who are, those among us on the call who have any sort of administrative involvement or leadership involvement. Those conversations really need to be having in those rooms when people talk about not only policy but language use, which contributes to this. I don't know how much that answers the question, but like I said, I think a lot of agencies will be on bits of policy discussions, laws that get passed, and yet in execution, they're not really in support of that. So that's why I mentioned that, a lot of healthcare agencies and healthcare institutions are present for policy that gets enacted on paper, and yet is it really being executed if the culture in which people are practicing doesn't actually align with that? I don't think it's impossible. It's just making sure that we're looking at both components of the piece, and that's why I constantly bring up systemic and institutional factors in terms of stigma.
Thank you, Lucien. We have 2 more questions and a comment here, if you have the time.
Sure.
All right. We have a question from someone, Samsung SMG950U smartphone, wondering if using coping strategies for using substances would be considered stigma.
What are you think? I think I understand the question. I want to say that the answer can be a yes if I understand the question correctly. In meaning, sort of, again, this bias in terms of when we look at certain types of interventions related to substance use, part of it being outcome based, right? That when we stay focused on, first of all, stopping use, that's the goal, or negative urine, that's the goal, and that their coping is all about, how to say no or how to this, as it's really about, we want to impact the outcome of a behavior that we don't like, versus are we really getting at core core symptoms or concerns that the patient has, if that's what part of what the question is getting at. So I think it can be. For some people, though, quite frankly, that is part of their, I mean, I think about young folks I have, because I see a lot of emerging adults, so 18 to 25, who are taking buprenorphine for heroin addiction. And they have gotten to a point where they're like, I want to be stopped, and yet I need to deal with, if I can't avoid going through X neighborhood, what do I do? Or if I can't avoid, like I can not hang out with these people, but these people are my family. What do I do when I go home for X? So I think it really is, it's coping with what? And is it patient-centered in terms of what the coping strategy is for? So I think the answer can be yes. It can be stigmatizing.
Perfect, thank you. We have another one from Anonymous who says, what were your thoughts about addiction medicine specialists? Did I hear that you do not believe in them?
Well, well, I am one. What I do, the issue that I have is that it's really contributed to, and this is the experience I have as an educator here, that we do not integrate what I do as a specialist very well with the main basic education of the future psychiatrists here. They want that to happen, and yet systemically it's not built in. So by viewing it as this specialty, which in many ways it's not really, I'm a kind of an odd duck, because I'm addiction medicine and I'm a pediatrician. I'm not a psychiatrist, but I'm very psychiatrically oriented, and what I do is behavioral health. Most people who end up doing addiction medicine specifically versus addiction psychiatry are usually family medicine, internal medicine. That's the bulk of them, and they really some of them do, but as a group very much focus on the medical aspect, or the giving medications aspect, or dealing with managing withdrawal, or that kind of thing, and are really not astute. Why would they be trained in the rest of psychiatry to really understand how substance use is woven into the rest of that? And so it can be part of both, like I said, barriers to access, because if systems are really looking for that specialist, there's never going to be enough of us. And where most people present, if when they do, is going to be to general psychiatry, or to just general medicine. And you really need to, if you're not going to provide all of the intervention for it, your case formulation, how you're putting things together, needs to be able to factor in the rest of psychiatry. Yeah, so it sounds weird to say that I think that there's aspects of the existence of my discipline that really just don't make any sense. And I'd rather see a lot more of the care be brought into general psychiatry, which we're perfectly capable of doing. So if that answers it.
Great, thank you. And one last comment from Wade here in regard to stigmatization.
I got it. Okay, go for it.
Wade says, I think one thing that clinicians can do to help along those lines is to call out that you're not your diagnosis, and furthermore, let the client know that a diagnosis is a part of the process of satisfying the needs of insurance companies.
I think that's great. I mean, I think, and that's one of many multitude of ways of doing it. And again, in my view, that's part of, it's part of, again, what was intended by both the spirit and practice of being evidence-based is that transparency. There's also that human component. Like you said, it's like you and me, it's two people in a room. You're a human being. We're here to, I'm here to get to know you and understand you as a person, and for the ways in which, I can help, help you relieve some suffering from whatever it is. It's depression, it's anxiety, it's whatever, that I'm going to focus on what's important to you. And I this matter of fact approach, have I used it? Sure. And especially when people are like, they come in because they have a copy of the DSM and they looked it up, it's like, do I really fit this? And we'll go through it and sort of explain again where they are, maybe on that page, but also then explaining this is what DSM is, and this is, let's just talk about what we're here to do. And so I say any way of doing that allows you to be transparent with a patient about where you're coming from in your thought process, as well as, again, you're talking about joining in. I'm here to be in the room with you. We're two people. So let's get this, you know, a lot of this stuff that's just, like, quite frankly, I mean, it's not bullshit, but I mean, it's, it dehumanizes. You're finding your way, which is one of many, of rehumanizing the process between us.
Well, thank you. I'd like to thank everyone for taking time to join us for today's presentation. I know there were a few questions that came in right near the end here, and if you would like to connect with Dr. Gonzalez and continue the conversation, please feel free to reach out to me via email, and I'll be glad to make those connections. We'd like to thank you all for joining us, and we'd like to extend an extra special thanks to Dr. Lucien Gonzalez for sharing his time and talents with us today.
Thanks, everybody.
Thank you all, and have a great weekend.
All right, you too.